Right. So thank you very much for the introduction. I'm Manisha, one of the neurologists with Frontier. I'm very honored to be here in front of all of you. I'm very grateful for the organizers for inviting me today. I am very nervous, so I will be displaying some movement disorders of my own, including a vocal tremor and an upper limb tremor. All right, so what's our movement disorder? So any abnormal movement which has a neurological basis is what we could classify as a movement disorder. I don't have anything more technical than that. It's very helpful to classify movement disorders, and this is what I use in practice as well. We have extra movements and we have reduced movements. So some of these terms are a bit technical, so I thought the easiest way is to show you a video. So we all, I think most of us are familiar with tremors. We can get tremors when we've had too much caffeine, or you can get tremors when you've inhaled your salbutamol inhaler too many times. And you get tremors in conditions such as Parkinson's, as in this lovely gentleman here who's got a left-handed tremor we can see. And then the camera will focus on his leg as well. You can see. All right, there are a couple of other extra movement disorders that I thought I'd bring up because I have actually seen that in some of the patients I've been seeing for Frontier. And these are terms that are helpful to explain to patients because then it explains to them why their loved one or family member is behaving the way they are. So dystonia is something that is caused by increased tension in a group of muscles. And actually in the good old-fashioned ways where they used to yank babies out through barbaric methods, we'd see a lot of dystonia then. That's the wry neck that children used to have when they were born, and actually came from chickens, the wry neck. So sometimes dystonias can be seen in non-worrying disorders, like I have a writer's cramp, so my hand will twist up when I've been writing for a long time and I've had to switch to the keyboard. So if you look in this video, this patient's got quite a fixed position of his arm. And when I play the video, it'll become quite apparent that there is sort of curling of the fingers, and he's got his arm like this in a bent position, almost like he's had a stroke. And that is actually a dystonia. So myoclonus, so in hospital, I see myoclonus a lot. So myoclonus is just a jerk, and sometimes all of us have it. So when you're lying in bed, totally relaxed, trying to sleep, you have a little jerk. That's actually a myoclonus, and that's physiological myoclonus. That's sleep jerks. But sometimes myoclonus is pathological, and you can see that in this video here. This is this gentleman with this fixed arm that I talked to you about, the dystonia, and there you go. That's the myoclonus. In him, it's quite dramatic. And then you get reduced movement. So bradykinesia, in medicine, we've borrowed all our terms from Latin and Greek. So brady means less, hyper means excessive, kinesia is movement. So bradykinesia means slow movement. And a lot of patients who've had family members with Parkinson's or some of the varieties of FTD will comment on the fact that they're so slow in doing things now. And that is this phenomenon. So we've got a couple of two ways of testing for this in the clinical setting. And the easiest way is to give a patient a repetitive action to do. So this is what I get patients to do. And if you've been through my clinic, you'd have gone through this. So the fingers are going slower and slower and slower. That's actually not a patient, that's my registrar. And then the other reduced movement is stiffness. So stiffness is very hard to illustrate on a video. It's more something that's felt than seen. So patients might have a stiff arm. And this gentleman in this video here, who's got that arm that's postured like that, is quite likely to be quite stiff in that arm. And in medical school, we're taught that it feels like you're rolling a lead pipe, and it's actually also called lead pipe rigidity. So these are the kinds of movements we can see in patients with frontotemporal dementia. So what's in a name? It's very confusing, and some of my non-neurology colleagues have problems with this as well. We have lots of terms to describe these movement disorders. So we have something called Parkinsonism, which means it looks like Parkinson's, but it's not quite. Then we've got Parkinson's disease, which lots of people will be aware of. And then we have this term called atypical Parkinsonism. And in neurology and a lot of medicine, if something doesn't quite make sense, you give it that title of atypical, and often becomes a diagnosis, unfortunately. So in the melting pots of neurology, so basically, if you put in bradykinesia, and then if you put in rigidity, that's enough to say someone's got Parkinsonism. And then they may or may not have tremor. So in Parkinson's disease, they have Parkinsonism, but usually they start off with tremor, and you've got a prelude of several years of tremor, someone's noticed, or sometimes they come to attention early, and sometimes it's about 5 years. It often starts on one side, and that is quite important for the neurologist to identify. And Parkinson's disease usually responds to therapies that we use for the disorder, which mainly center around increasing dopamine levels within the brain. So that's quite a typical picture of someone with Parkinson's. This is a very old picture. I'm sure I saw it in textbooks when I was a medical student. So patients are often stooped forward, they shuffle, they often have a tremor on one side, and the arm doesn't swing when they're walking. And they can stop, and as if they're stuck to the ground. We call that freezing. So what is atypical Parkinsonism? So it is presence of these features I told you, the slowing, the stiffness in the limbs, but they don't fit the remit for Parkinson's disease. These patients may not have tremor. They can be quite symmetric, whereas with Parkinson's disease, it usually starts on one side. They also have other features, abnormal eye movements or falls. They tend to, unfortunately, progress more rapidly than Parkinson's disease, and they often don't respond to therapies. And I have to tell you that this is not a diagnosis we make on the spot. It often takes us a few years to come to this conclusion, which is sad. It's not good for patients to get a diagnosis now of what they should have been diagnosed with 2 years ago. But that's the limitation with the neurodegeneration. The full picture is often not seen when you see the patient for the first time. So we have a few atypical Parkinsonisms, but I'm going to talk about the two in red. That's progressive supranuclear palsy and corticobasal syndrome. And these are the two that I encounter in the clinic here as well. So progressive supranuclear palsy is one of those syndromes that is quite old, and lots of the videos are very old, but doctors still wore medical lab coats. You get this constellation of features that forms Parkinsonism, that patients have early balance issues and falls in contrast to the Parkinson's disease patients, where you shouldn't see falls for at least 5 years. They also get this typical eye movement disorder. And, I examine eye movements every time I see a patient, and this is the reason. So I'm playing you this video of this patient with PSP, and you can see he's walking very stiffly. And unlike the stooped Parkinson's patient, he's sort of leaning backwards, and he can't actually bend down to look at something because his eyes don't move down. These patients often have problems walking downstairs. So just honing up the eye movement problem here. So this patient's been asked to hold their head steady and look up and down. Oh, sorry, I knew something would go wrong. But they can't, and they have to move their head to look up and down because the eyes won't do it of their own volition. And that's part of the problem here. So falling downstairs is really an important thing. Patients often, looking downstairs isn't a problem, so they can fall downstairs. And then patients often looking backwards that way, and they fall backwards when they're walking on level ground. So the other atypical Parkinsonism is corticobasal syndrome. Again, the same constellation of features that form Parkinsonism, but they also have a few features here, sound quite technical, but apraxia is basically the difficulty in carrying out an action despite normal strength and normal sensation. And I test a lot of things. I joke that I have this basket of instruments of torture there for patients, but that's all, most of it's looking at apraxia. They also have dystonia that I've talked about and myoclonus. Another feature that is quite unique to corticobasal syndrome is this higher sensory involvement. So some patients might have gone through this. I'd have given them something to hold, I'm usually scrambling for something in the RA's office, like a battery or a key, and I ask them to guess what they're holding in their hand, and that is that higher center function. So I've got the same patient we saw earlier, but this patient's actually trying to use that left hand to do something, but he can't, and that's apraxia. He's actually trying to show them something. I think he's trying to grasp the pen that they're holding out, but he's not able to. And you can see that left hand is just held so immobile, not participating in things. And now he's trying to show them how he would hammer a nail. And he's meant to pretend to hold a hammer in his hand, but it doesn't quite work that way. So finally, he just gives up and he's trying to use the hand as a hammer. And then the other thing we can have is difficulty using tools, even day-to-day tools. So this person's using a toothbrush to brush their hair because the pathway that allows them to recognize what they need to use to do a particular thing isn't working. So how do we diagnose PSP and CBS? So sadly, despite all these advances, we rely very heavily on clinical assessment. And as I said, sometimes it can take years when the typical clinical features are absent. We do have diagnostic criteria, but often patients don't come with the whole house when we see them the first time. We have no diagnostic test for these patients. We don't have a blood test. We don't have anything that will tell us the first time we see a patient, this is what you have. If we can do that, often it's quite late. Often I'm seeing patients 4 or 5 years into their illness. So sometimes MRI scans can be useful, but even then, these are soft signs. These are not hard diagnostic features. So in PSP, this is the part of the brain where my mouse is. That's the part of the brain called the midbrain, which is right at the back. And in patients with PSP, you can see there's a difference between the top frame and the bottom frame. This is much narrower, it's thinner, and it looks like a beak if you can bring your mind to think of it. And it's actually called a hummingbird sign, but these are all soft signs. I mean, they all depend very much on visual inspection of a scan and can vary from observer to observer. In corticobasal syndrome, you get this, these are the parietal lobes here, and you get atrophy or shrinkage of one side classically, but we often see variations to this. So that's what we're seeing on the scan. This left side is thinner than the right side, although both are equally damaged, and the same with the right. So we can use those. So in my research, I've been looking at movement disorders across the FTD spectrum, and I have found that language and behavioral variants of FTD can present with movement disorder in 10 to 15%, and that is at the first time we're seeing patients here in Frontier. I also found that 1/3 of the patients with PSP don't have a movement disorder when they come to clinic, so they're coming with cognitive and language problems, not with movement disorders. So how does the presence of movement disorder influence FTD? So we have, as I said, problems with accuracy of diagnosis and also early diagnosis. Often I'm changing diagnosis in clinic, and some of you may have come across this too. For example, about a few situations where I've changed the diagnosis from a language disorder to corticobasal syndrome, just because there's been evolution of the disease. Also, I found in my study that it has a negative impact on cognitive measurements. So moving on to management of movement disorders, we know that FTDs are currently incurable, but Yes. So you know how when patients come here, they get a variety of neuropsychological measurements. These include language, memory, visual. So across the board, people who had movement disorder with the background diagnosis of one of the FTDs did worse than the ones who didn't. So we know that FTDs are currently incurable, but we do focus on symptomatic therapies. Where Parkinson's disease is incurable, but we have treatments for the movement disorder part of Parkinson's disease. So I think it may be worth trying some of these same treatment strategies for the movement disorders in FTD patients. So it's with anything, we have pharmacological strategies, that's the pills and potions we use, but also non-pharmacological strategies. I'm a great believer in a holistic view of anything we tackle in medicine. So I won't go into detail into this slide because I'm very cognizant of time and the fact that we're all post-lunch. But basically, managing some of the Parkinsonism features, the bit that makes the patient look like they've got Parkinson's disease, I think it is worth trying therapies that are aimed at dopamine. So we have 3 in Australia. The ones I've put on the side, there's Matopar, Cinemet, and Kinson. So usually I will give people a trial of this no matter what the underlying diagnosis is, as long as they've got some features that look like Parkinson's. And the tremor, there are lots of medications available for tremor, but nothing really works. So these are the 2 I go to. One is a beta blocker called propranolol, and somebody suggested I should take it before this talk because it calms your nerves down. And then the other one is gabapentin. I haven't had much of success, but this is what's available. Then management of dystonia often is a difficult situation because the medications we use can worsen cognition and can cause some delirium. If dystonia is really bad, there is some room for trying therapy such as botulinum toxin, which is on PBS. With the myoclonus, it's a mixed bag. Often I don't focus on treatment of this unless it's disabling.
There was Parkinson's type mobility issues, and if the person had medication, but they had PSP, would it help or would it sort of impact negatively?
So that's an excellent question. Basically, we don't know till we've tried because we've got no way to know which patient would respond anyway. The rule of thumb is it's worth a try, keeping in mind that sometimes higher doses are needed. So an ancillary situation is where the Parkinson's features are caused by, say, strokes. And that's been studied a little bit. And they say it's worth a try. Most patients don't respond, but you really have to try higher doses. In terms of side effects, so these drugs itself, they've only got a half-life of about 4 hours. They disappear from the body. So in terms of lasting side effects, we don't think there are any. Yes, if you try really high doses, you can cause blood pressures to drop, a little bit of confusion and delirium, but we always try low and go slow. That's the motto when you're using these medications. So I'm a bit more conservative than some of my colleagues. I generally don't go over 800 milligrams a day, but you can go up to 1,000. I think in Europe, some people use 1,200, 1,500 milligrams in total a day, which is quite a lot. We have other techniques of knowing. Sometimes you can give people in a supervised setting a large single dose to see if they'll respond. Generally, I would not go more than 800 milligrams. So non-pharmacological strategy is my favorite part of today's talk. So you can see the left top is sort of just ameliorating falls prevention and using simple walking. But then towards the right, the bottom, you might have more adventurous gym-based or rehabilitative programs. There's quite a lot here. I can't go through all, but I'll go through a few. So walking, it's easy to tell people to walk. You've got to make sure they're safe when they're walking. So about 30 minutes a day on flat ground, avoiding dual tasking. The problem we've got here is all the non-pharmacological strategies have mostly been studied in Parkinson's disease. There are a few that have been studied in PSP and CBS, and I'll be referring to them. But walking is fairly general, so I thought I should bring it up. You have to tell the patients to use assistive devices if they're using, so not to walk without their walker or their stick or their 2 sticks, and sometimes the Nordic walking poles, under supervision if required. So it's important when you tell people to walk because the safest person is the person who doesn't walk. To identify those who are at risk of falling, use mitigation strategies in that situation. Also keeping in mind that, as we grow older, we're at risk for osteoporosis. So you might not be able to prevent falls, but you can prevent fractures. And this is really interesting. So this is rhythmic auditory cueing. It has actually been studied in PSP and CBS as well, but in a variety of neurological conditions. So stroke, cerebral palsy, ataxia, and there are actually apps for this. Oh, so Penny's told me I need to move on. So basically, this was a group of patients with PSP and CBS, and they found that using these auditory cues improved not only the cadence, that is steps per minute, but also velocity and stride length. And with some of these, it was actually persistent even after the cueing was taken. So basically, you get the patients to walk to a beat, and the beat can be anything. It can be a march beat, it can be someone shouting left, right, or 1, 2, 3, or to your favorite song. And the way it works is it's supposed to entrain the movement disorder pathways by replacing the mechanism that's not working. And also there must be an emotional component. I'm sure I'd walk better listening to my favorite song. So I might skip this video, but actually it's quite nice to show you because this is a man with a cue on the left and no cue on the right. And you can see he's sort of much quicker and more confident with his feet with the auditory cue, whereas he's shuffling quite a bit where there's no cue. So Tai Chi, this is one of my favorites. So versus routine exercise, Tai Chi is much more superior, about half more in fall prevention. So I tell all my Parkinson's patients to do some Tai Chi. And this is a group of patients with Parkinson's doing Tai Chi. And if you can't stand and do Tai Chi, you can sit and do Tai Chi. All right, I'm almost done. So dancing. So there is dance. Before COVID, there were a lot of dance groups for Parkinson's, and there's no reason why they can't be used in other conditions where there's movement disorders. All right, and pedaling. I constantly tell my patients to pedal. So you can join a pedaling class with either a fixed or a stationary bike. You can have apparatus like this, or you can even just have standalone pedals that you get in Kmart for about $40 and put them on the table, use it for your arms, and put them on the floor, use them for your feet while you're watching TV. So something little and simple that you can do every day. And we don't know why pedaling works, but it sort of enhances its circuitry behind the movement disorder that allows things to work better. And even wheelchairs can be adapted with pedals to help patients move. So this is my last slide, Penny. So principles of exercise therapy is to start early, be effective, around 30 minutes a day, whatever you take. It has to be challenging to have effect. You develop plans jointly with patients and their family, you individually tailor them to patients, and make sure you put the patient's safety at first and provide adequate supervision. Thank you.